Bismillahirrahmanirrahim. From today onward, we'll be doing with the lower limb. So, starting the lower limb, so the first point is about the knee joint. So, in the knee joint, they're telling us about the ligaments which are connecting the knee joints. What is the knee joint? Knee joint is basically a joint that is formed between the three bones. First one is the femur, that is above. This one, the femur. Second one is the tibia, that is below, medially, and fibula, that is below and laterally. Now let's talk about ligaments. Cruciate ligaments, anterior cruciate ligament and the posterior cruciate ligament. Cruciate is basically, this is a crucifix, right? Across, you may say, the cruciate. So here you can see a cross that is present inside the knee joint. Something is coming from here to here and here to here. Two diagonal lines making cross can be seen. So the anterior cruciate ligament starts from the lateral femoral condyle to the anterior tibia. It resists the anterior movement of the tibia. So anterior will resist the anterior movement, first thing. Secondly, suppose we are having the anterior view over here. So this is the lateral aspect, this is the medial aspect, right? And here we have the opposite of that. So this is the lateral aspect and this is the medial aspect. So let's divide these pictures. Now, the anterior cruciate ligament is coming from the lateral femoral condyle. Yeah, like here you can see the anterior one. It is originating from the lateral femoral epicondyle. I'm sorry, no, it's not epicondyle, it's condyle. So lateral femoral condyle to the anterior tibia. Okay. Then posterior cruciate ligament, it is from the lateral femoral condyle to the posterior tibia. Lateral. No, it's not lateral, it's medial. So posterior cruciate ligament is from the medial femoral condyle to the posterior tibia. It resists the posterior movement. As you can see here, from the medial femoral condyle to the posterior tibia, it's posterior cruciate ligament, and from the lateral, here you can see this is medial one. So from the medial femoral condyle to the posterior tibia, from the medial posterior condyle, from the medial femoral condyle to the posterior tibia, what do we have? The posterior cruciate ligament. So here is the mnemonic for that, that is LAMP. Lateral femoral condyle to the anterior tibia is anterior cruciate ligament, and medial femoral condyle to the posterior tibia is posterior cruciate ligament. So it becomes LAMP, right? So it is the posterior movement. And that is also simple. Here you can see the anterior cruciate ligament is resisting the anterior movement, while the posterior cruciate ligament is resisting the posterior movement. Got it? Secondly, here you can see that this one anteriorly, so you can make an analogy as well. So suppose that when the flexion is there, so during the flexion, the 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 femur is being moved like this. So like suppose this is the tibia and the femur is being, I'm making a little picture, so the femur is moving like this. So there is a chance for the sliding of femur anteriorly when the flexion is there. So to resist the anterior movement of the tibia while flexion, the anterior cruciate ligament plays its role, while the opposite movement is occurring during the extension. Suppose that this is the tibia near below and the fibula is now extending, not fibula, the femur is extending now. So there is a chance for the femur to move posteriorly while extending. Yes, I guess I'm saying the right thing. Yeah. So to resist this movement, like when the person is standing straight or extending the knee joint, so in that case, to prevent the posterior movement, we have the posterior cruciate ligament. Here you can see these cruciate ligaments. So I guess there's a picture of that. So this is the ligament cruciato anteriore. So anterior cruciate ligament is this one, and this is the posterior cruciate ligament. So let's move to the next page. These are a lot of different ligaments. Let's see the name of them and then we'll come back to them later on. So here you can see that these are the menisci. Menisci is basically on the joint surface, like on the articular surface of the tibia and the femur. We have these lateral menisci and the medial menisci. So these are basically semicircular structures which are which are basically giving smooth surface for articulation. You may say that they're just like the glenoid labrum which we saw in the joint of glenohumeral shoulder joint. So there's something like that. Just forget about these. This is the lateral lemniscus, and here we have the medial lemniscus. Sorry, not lemniscus. It is meniscus. So lateral meniscus over here and medial meniscus here. Here is the patellar ligament. Then we have lateral articular surface. So the menisci are lining the articular surfaces as I just stated. So lateral articular surface is lined by the lateral meniscus, while the medial articular surface is lined by the medial meniscus. Okay. Then let's talk about the sartorius muscle. So here the muscle biceps femoris and posterior cruciate ligament. Yeah, here we have the posterior cruciate ligament moving from the medial femoral condyle to the posterior surface, while the where the anterior cruciate. So here the anterior cruciate ligament is moving from the lateral femoral condyle to the anterior surface. So it goes something like that. So let's forget about it. Then we have the gracilis tendon and stuff again. Okay, so what do we have here? So this is our posterior axis, I guess. There's the medial femoral condyle and lateral femoral condyle. From the medial to the posterior of the tibia, we have posterior cruciate ligament, and from the lateral to the anterior of tibia, we have the anterior cruciate ligament. This is medial tibial condyle and lateral tibial condyle and head of the fibula. Okay, so let's move forward. Collateral ligament, the lateral and medial bands. So collateral ligaments are lateral and medial bands. Suppose this is the tibia. I guess here we have a picture of that. So this is femur and femur above and tibia below. So the lateral band which is connecting these in the joint together is called as lateral and medial collateral ligament. So the collateral ligaments are lateral and medial band. They resist the varus and the valgus deformity. Varus means bow-legged, lower leg adducted. So here you can see this is valgus, by the way. So varus means that the lower leg is adducted. It is moved inside. When the valgus is knock-knee, lower leg is abducted. Here you can see the lower leg is abducted or moved outwards. If the lower leg would have moved inside, that would be called as varus movement. Medial collateral ligament. The medial epicondyle of the femur is connected to the medial condyle of the tibia, that is medial collateral ligament. It resists the valgus stress. So the medial is going to resist the valgus stress because it is valgus means the lower leg is abducted. Lower leg is so it's abducted. So the medial condyle is present over here. It does not allow. So suppose, just give me a second. So this is the ligament over here. Whenever the lower leg tries to move outside, this will be stretched and this will not allow the leg to move, to be abducted. But if this movement is, if ligament is laxed or absent, so in that case this leg can move outwards, and when it can move outwards, so we have the deformity that is called as valgus deformity. Medial collateral ligament, medial epicondyle of the femur, medial condyle of the tibia, and resist the valgus stress. Lateral collateral ligament, medial epicondyle of the femur to the head of fibula. So here you can see this is head of fibula. So lateral collateral ligament between the fibula now and everything, that although there are three bones which are involved or which are in close proximity to the knee joint per se is a joint between the femur and the tibia. That's it. The fibula is an accessory structure which is making a joint with the tibia. So it is a tibio-fibular joint. Not the fibula is not connected to femur in any way other than this collateral ligament. So that is how the knee joint is a complex kind of a joint, but in very particular surfaces or in very articular aspects, if we are speaking. So in that thing, the femur is just articulating with the tibia. It is not articulating with fibula in any sense. Then the lateral collateral ligament will resist the varus stress again due to the same analogy. This is the lateral collateral ligament over here. Now whenever this lower leg tries to adduct, this will be stretched and this will not allow the adduction. If this is laxed or this is absent at all, so in that case the lower leg can be adducted, and that deformity is called as varus, I think so. Not varus, but it is a varus deformity of the lower legs. What are menisci? Menisci are two crescent shaped pads, medial and lateral, fibrous tissue and cartilage. Okay, they're made up of fibrous tissue and cartilage between the tibia and the femoral condyles. In MRI, it appears triangular in shape. Okay. So what is anterior draw sign? We studied about that in the 100-point videos. So anterior draw sign means bending knee at 90-degree angle, anterior gliding of the tibia relative to the femur due to anterior cruciate ligament. Lachman test also tests the anterior cruciate ligament but is more sensitive. Okay, anterior draw sign. Okay. But is more sensitive in case anterior gliding of tibia relative to the femur with knee bend at 30-degree angle. So anterior draw sign means that when the anterior cruciate ligament is not patent enough, so the tibia will be moving anterior in reference to the fibula when we do the flexion movement. Okay, so in that case it is called as anterior draw sign, that in anterior draw sign bending of the knee at 90 degree will increase the anterior gliding of tibia. Give me a second. I just said something over here. I guess that was some incorrect knowledge. So just give me a second to correct that. Okay, so let's correct that. For that, let's remove it because that was the draw signs were confusing me. So I cross-checked from excellent videos from where I saw that primarily. So I was wrong. So let me correct that. So listen. Now, if this is the femur and it is sliding on the tibia. So whenever there is flexion movement, there is a chance that during the flexion, because this is the body over here, here we have the body, right? The total body of the person with arms and leg, arms and head and all that. When we are flexing, we are putting the weight of the body over here, right? So there is a chance for the femur to drop backwards. To prevent this posterior movement, we have which ligament? The posterior cruciate ligament. Whenever we are extending, we are standing upwards, so the weight of the body is anteriorly, moving anteriorly. So there is a chance that whenever we are standing up, or when we are extending our leg, so the femur has a chance to fall anteriorly, and in that particular case, the anterior cruciate ligament will prevent the anterior movement of the femur. Now we are talking in reference to the femur only. Flexion can cause the posterior fall down of femur, while extension can cause anterior movement of the femur. To prevent these movements, we have the cruciate ligaments. Now let's move on. So these are the draw signs. That anterior draw sign. Now we are talking in reference to the tibia. Remember, the movement between the tibia and tibia and femur are opposite to each other. If we are saying the tibia is moving forward, so that is also that is synonymous to femur moving backwards, right? Because there are relative movement between both of the bones. So anterior draw sign, bending the knee at 90-degree angle, increases anterior gliding of tibia, which means the femur is moving backward relative to the femur, right? Due to the anterior cruciate ligament injury. Whenever there is anterior cruciate ligament injury, during the flexion, the tibia can move forward while the femur can fall backward. Lachman test also tests the anterior cruciate ligament, but is more sensitive. Anterior gliding of the tibia relative to the femur with the knee bent at 30-degree angle. Okay. Then we have posterior draw sign, bending the knee at 90-degree angle, increased posterior gliding of the tibia due to posterior cruciate ligament, right? So there's the posterior cruciate ligament. And another thing that I just want to say it, that this analogy is just an analogy to make you understand the basic functionality of the anterior and posterior cruciate ligament. It has nothing to do with the physiology. Normally, or when we are doing the test, so here you can see that both anterior and posterior draw signs are elicited when the knee is flexed. So there is no concept of extending the body. So remember that these two things, which I previously have seen, have shown you, they are just in reference to the conceptualizing purpose, and they are not like very physiologic or pathologic signs associated with that. So firstly we saw the anterior draw sign. Now we're talking about the posterior draw sign. Posterior movement is being resisted by the posterior cruciate ligament. Remember that. Now bending the knee at 90-degree angle will increase the posterior gliding of tibia relative to the femur due to the posterior cruciate ligament injury. Okay. Then we have abnormal passive abduction. Abnormal passive abduction means that knee either extended or at 30-degree angle lateral to the valgus force, medial space widening of the tibia due to the medial cruciate ligament injury. Whenever there is medial cruciate ligament injury, so there is a chance of valgus stress, that is the lower leg can move laterally. Here you can see that the lower leg is moving laterally because the medial cruciate ligament is not functioning properly. That is called as abduction or valgus force. So knee either extended or at 30-degree angle lateral to the valgus force, medial space widening of the tibia, that is medial cruciate ligament injury. Okay, then we have abnormal or passive adduction. So in that case, knee either extended or at 30-degree angle, medial varus force, okay, lateral space widening of the tibia, lateral cruciate ligament injury. So the point of abnormal passive adduction is that whenever there is lateral cruciate ligament injury, so the leg will move inside or there will be varus deformity. So this is the same concept which we previously have seen. Now they're just talking about the concepts. Then McMurray test. So during the flexion and extension of the knee with the rotation of tibia and foot. So duration of flexion and extension of the knee with the rotation of tibia. Pain, popping of the external rotation, medial meniscus tear. So this is something that we are going to talk about in the meniscal tear. So there is medial meniscal tear, external rotation stresses the medial meniscus. We'll talk about menisci, I guess, over here. Medial cruciate ligament, yeah. So we're going to talk about that. So, or we talked about it here. Okay. So whenever there is medial meniscal tear, so the external rotation will be painful, or there will be a popping sound associated with the external rotation. Here you can see that we are doing the external rotation of the foot, and there is a pain that is elicited in the flexed knee during flexion and extension of the knee with rotation of tibia and foot. Pain, popping or external rotation of the medial meniscal tear. External rotation stresses the medial meniscus, and pain, that is popping on the internal rotation. So if we are doing the internal rotation and we feel the popping sensation or pain sensation, lateral meniscal tear, internal rotation stresses the lateral meniscus. The internal rotation will stress the lateral, Okay, so internal rotation is stressing the lateral meniscus, and the external rotation is stressing the medial meniscus. So make some mnemonic out of that. I guess INL is something like international, or XM is some exanthem. Forget about it. So make a mnemonic like that. But remember that the internal rotation will challenge, or will cause a stress on the lateral meniscus, while external rotation will cause a stress on the medial meniscus. First thing. Secondly, the point I wanted to say is that I have a senior who had a test step 1 exam. So in that step 1 exam, they asked about these angles, like anterior dorsine at 30-degree angle by Lachman test, and 90-degree at by the dorsine test, blah blah blah. So these angles were also asked upon by in that particular test. It was a difficult question, but they can ask about these questions as well, these angles as well. So remember these angles. So now let's move forward. Okay, so now common hip and knee conditions. Medial collateral ligament injury. Whenever the medial collateral ligament is injured, it attaches proximally to the medial epicondyle of the femur and resists the force that push the knee medially. If the knee is being pushed medially, that is knock knee, so the leg will be pushed laterally, right? Medial collateral ligament injury typically occurs after twisting injury or blow to the lateral knee while the foot is planted. Valgus stress injury, right? So let's go back and see the valgus stress injury. So here you can see the valgus stress injury, that the knee is moved medially while the leg is moved laterally. So this is called as a valgus stress deformity, and this is seen whenever there is medial cruciate ligament injury. And medial cruciate ligament injury can happen whenever we have blow to the lateral knee while the foot is planted. If there is blow to the lateral knee while the foot was planted, let's go here. Suppose that there is blow to the lateral knee over here. There is something like a hammer or something with which there was a blow. So that blow will cause the knee to move inside, leg to move outside, and there will be a stress or shearing stress on this one, which will cause a tear to the medial collateral ligament. Then we have, let's come back, medial collateral ligament. Then talking about the lateral collateral ligament injury, rarely injured in isolation, often trauma of the medial knee, abnormal passive abduction, abnormal passive abduction, and lateral space widens. So here they're saying about abnormal passive abduction. I guess it is the abduction of the knee, but I'm not able to understand this particular line. And there is lateral space widening, so it means that suppose this is the femur, and here we have the tibia below that, and this is the medial aspect, and here we have the lateral aspect. So this space between the femur and the tibia, that will widen because of the absence of the lateral collateral ligament. Then there is a thing that we call unhappy triad. So unhappy triad means common injury in the contact sports due to the lateral force applied to a planted leg. If there is lateral force applied to a planted leg, so resultantly there will be an unhappy triad. Can classically consist of the damage to the anterior cruciate ligament, the medial collateral ligament, and the medial meniscus. So whenever there is force applied to the lateral knee, so we have seen it here that whenever there is medial collateral ligament damage, it happens whenever there is a blow to the lateral knee. So unhappy triad, common injury in contact sports due to the lateral force applied to a planted leg. That is, leg is planted on the ground, and due to some reason there was some injury to the lateral aspect of the leg. So it will result in 3 ligamental tear. First one, anterior cruciate ligament. Second one, medial collateral ligament, and third one is the medial meniscus attached to the medial collateral ligament. Yeah, because it is attached to the medial collateral ligament, and that is why it can also be damaged. However, the lateral meniscus injury is more common. What? Okay, so there can be a triad of these 3, but this can be normal, and the lateral meniscus can also be injured. It presents with the acute knee pain and signs of joint injury and instability. So here you can see this is femur and the patella and the tibia and anterior cruciate ligament. The lateral force when it is applied over there, so there is a chance of damage to the medial collateral ligament. This one. Then I'm sorry, there is some home shifting going on in my place. So we were talking about the lateral blow. So in that case, these 3 things can be damaged: anterior cruciate ligament, the medial collateral ligament, and medial meniscus, because it is attached to the medial collateral ligament. But the more common injury is to the lateral meniscus. So either of the 2 can be damaged. Either of the 2 menisci can be damaged, but these 2 are damaged for sure. So here you can see that whenever there is lateral force, so resultantly the lateral collateral ligament is in place. The posterior cruciate ligament is also intact. The damage is to the anterior collateral ligament, this one, which resists the anterior dislocation of the femur. So now the femur can be dislocated anteriorly. Anterior dislocation. No, again I'm wrong. Okay, so the anterior dislocation of the knee joint. Remember that. So anterior cruciate ligament is resisting the anterior movement, but you can say femur. Yes, yes, I was not that wrong. So anterior dislocation of the femur is resisted by the anterior cruciate ligament, and if that is damaged, so there can be anterior dislocation, as well as we have damage to the medial collateral ligament. So this means that there will be valgus deformity, that the lower extremity will be abnormally abducted, and then we have the medial lemniscus that is also torn, because medial lemniscus is intimately in contact with this medial collateral ligament. So that is what can be torn. But since there is a lateral force, so there is a chance of damage to this lateral meniscus as well. Now you can see it over here. There is another picture that whenever there is direction of force which is directed laterally, so there will be torn anterior cruciate ligament, then the torn tibial, medial collateral ligament, and the medial meniscus is also damaged. So this is an unhappy triad. Now NBME point is joint line tenderness. Usually medial collateral pain, medial collateral ligament pain, lower usually pes and serine bursa. Joint line tenderness. So if there is joint line tenderness, if it is higher, so it means that there is some medial collateral ligament pain, and if it is lower, so there is pes and serine bursa. I don't know what anything about this one. So remember that if there is, let me see what pes and serine is. Pes and serine bursa. Pes and serine bursitis. So pes and serine bursitis means that pes and serine bursitis is a clinical entity associated with the pain at the medial knee and proximal medial tibial region. So there is pain at the medial knee and the proximal medial tibial region. A more generic term, pes and serine pain syndrome, has been applied to refer to the medial knee pain, which may or may not include the inflammation of the bursal sac. Okay, so what is pes and serine? Where is that bursa? Pes and serine bursa. The pes and serine describe a region where the tendinous structure of the semitendinosus and the gracilis and sartorius muscle join to insert the medial knee. So this is pes and serine, where three muscles, which are semitendinosus, gracilis, and sartorius, are going to adhere to the medial knee. So over here, this is pes and serine. The three muscles are attaching, which are sartorius, semitendinosus, and gracilis. I'm sorry, sartorius, semitendinosus, and gracilis. All of them together are inserting on the medial surface of the knee joint, on the tibia. So that thing is called as pes and serine. Now, if in the on the medial side of the knee there is pain, if it is higher in location, so it is due to the medial collateral ligament damage, and if it is lower, so then it is due to the pes and serine bursitis or pes and serine bursa. I guess it is associated with that. Now moving forward to the anterior collateral ligament injury, most commonly injured in non-contact injuries involving the sudden decelerations and pivots or an extended knee. Okay, so anterior collateral ligament does not allow the anterior dislocation, right? So whenever the leg is extended, the femur has a chance to be dislocated anteriorly. So if there is some injury when the person was having an extension of the knee joint, so that can cause anterior cruciate ligament damage. Physical examination will show excessive anterior motion of the tibia with respect to the femur. The medial geniculate artery provides the primary blood supply to the anterior cruciate ligament, and injuries are characterized by the rapid onset hemarthrosis and knee swelling. So there is anterior cruciate ligament, and the injuries are characterized by rapid onset hemarthrosis and knee swelling, because the medial geniculate artery provides primary blood supply to the. So whenever there is damage to the anterior cruciate ligament, there will be bleeding from the medial geniculate artery, and that bleeding that is coming out of the medial geniculate artery can cause rapid onset hemarthrosis, that is blood in the joint cavity, and the knee swelling. After that, we have bursitis. A bursa is a fluid-filled synovial sac that serves to alleviate pressure and that serves to alleviate the pressure and friction at the bony prominences and the ligamentous attachment throughout the body. Now, some bursae are normally present. Like some, the subacromial bursa is normally present, physiologically present. If there is some increased resistance to an area, like due to some physical exercise or some other area, in some other stresses over there, in that case bursa can also develop later on in life. So they can be bursa which are primarily present throughout the life, and then there are secondary bursa. They're not called secondary bursa, I'm calling them secondary bursa because they develop later in life. So bursa is any fluid filled synovial sac that serves to alleviate the pressure and friction at the bony prominences and the ligamentous attachments throughout the body. Trochanteric bursa, inflammation. Okay, so trochanteric bursitis, inflammation of the gluteal tendon and the bursa, gluteal tendon and the bursa lateral to the greater trochanter of the femur. presentation. So let's see where the trochanteric bursa basically exists. Trochanteric bursitis. Trochanteric bursa. Okay, so trochanteric bursa is located over here. It is present between the trochanteric bursa is located deep to the gluteus maximus muscle as it inserts on the fascia lata or iliotibial sac. It covers the posterior facet of the greater trochanter as well as the insertion of the gluteus medius tendon on the lateral facet of the proximal region of the vastus lataris. Here you can see in this picture that the greater trochanteric bursa is basically present between the greater trochanter and the insertion of the gluteus maximus, I guess. Here you can see the trochanteric bursa. Yeah, so there's the trochanteric bursa, and this is the gluteus maximus. The gluteus maximus is cut. So between the gluteus maximus, it is not that between the tendon of that, between the muscular body, you may say that. So this is gluteus maximus, and this is the greater trochanter of the femur. So between these two, we have the trochanteric bursa. We also have gluteus medius bursa between something like that. So this is the trochanteric bursa. If this gets inflamed, so we get the trochanteric bursitis. So what is the inflammation of the gluteal tendon? The gluteal tendon and the bursa lateral to the greater trochanter of the femur. Presentation: sharp, intermittent pain at the lateral hip and thigh. Pain is increased with the pressure on the affected hip, for example, the lying on that side, and with walking. Treat the pain with NSAIDs, heat, and stretching. Patellar, prepatellar bursitis. So prepatellar bursa is over here. Patella, this is pre-patella bursa is present anterior to the bursa, between anterior to the patella. So if there is some bursa that is present between the patella bone and the skin, that is called as pre-patellar bursa, and that inflammation in that bursa will cause pre-patellar bursitis. It lies between the superficial surface of the patella and skin, as you can see in this arrow over here. Can caused by repeated trauma or pressure from the excessive kneeling, also known as housemaid's knee. Housemaid is, you know, a woman who works in home, so she has to kneel down on the floor again and again. So that housemaid's knee is a condition in which there is excessive kneeling whenever the person kneels or, you know, sits like that. So suppose there's a person and he's sitting like his knees bent on the floor. These are the arms, and she has to you know, clean the floor with that. So this movement with kneeling of the knees can cause pre-patellar bursitis, and that is why it is also called the homemaid's knee, housemaid's knee. This is femur, this is tibia. Here we have the anterior MSK, blah blah, and the pre-patellar bursa. So patella will be somewhere here, and this thing is called pre-patellar bursa, and that is inflamed. That is why it is, you know, radio opaque, and we can see the white fluid in that because of the inflammatory fluid accumulation. So that is called as pre-patellar bursitis. Now we have suprapatellar bursitis. This bursa over here is the suprapatellar. Like you know, the suprapatellar bursitis is not a separate synovial. It's not a separate synovial cavity. It is a continuation or superior continuation of the knee joint cavity. So this is called as superior or suprapatellar bursitis. So suprapatellar bursitis, superior extension of the synovial cavity between distal end of the femur and quadricep muscle and tendon. Usual place of intra-articular injections. Suprapatellar bursa is the usual place of intra-articular injection when we have to, you know, anesthetize the knee joint, or we have to do some operations in the knee joint. So we give injections inside the suprapatellar bursa. Then we have anserine bursitis. So it presents with pain along the medial knee. This is pes anserine bursitis, which we talked about over here. Yes, here. So lower uli pes bursa, the pain in the knee joint. Okay, so present with the pain along the medial knee and well-defined tenderness approximately 4 cm distal to the anterior medial joint margin of the knee. It frequently results from obesity and overuse in the athletes. So in the anserine bursitis, it presents because of obesity or the overuse of the knee joint in the athletes that can result in anserine bursitis, and we saw in this picture, not in this picture. I guess over here. Yeah. So this is anserine bursa. The pes anserine bursa is over here between the tendinous attachment of the sartorius, the semitendinosus, and the gracilis muscle on the tibia. Then we have over here. Let's come back to the PDF. So what is Baker cyst? Extrusion of the synovial fluid of the knee joint into the bursa in patient with osteoarthritis or inflammatory joint disease. Extrusion of the synovial fluid. Extrusion of synovial fluid from the knee joint into the bursa in the patient with osteoarthritis or inflammatory joint is called as a Baker cyst. Popliteal fluid collection in the gastrocnemius or semi-membranous bursa. Okay, in the gastrocnemius semi-membranous bursa between the two muscle tendons, commonly communicating with the with the synovial fluid. So Baker's cyst is present most of the time in the popliteal fossa on the posterior surface of the leg. So in that posterior surface, bursa between the two tendons. What tendons? The gastrocnemius and semi-membranous bursa. Let me see that. Gastrocnemius semi-membranous bursa. Gastrocnemius semi-tendinous bursa. I find lower limb more difficult than the upper limb because of some unknown reasons, because the joints and everything is just bigger over here. So the bursa, what we are talking about. On the posterior side, we have articular cartilage in the lateral. Okay, so lateral subtendinous bursa, lateral subtendinous bursa. What? Lateral subtendinous bursa of the gastrocnemius muscle. That's over here. So here you can see the joint cavity and this black space, the which my cursor is following right now. This is the synovial cavity of the joint. If the synovial fluid comes out of it like this, and there is some accumulation in the popliteal fossa behind that, that thing is called as a Baker's cyst. So let's talk about Baker's cyst. They're saying that extrusion of the synovial fluid from the knee joint into the bursa in the patient with osteoarthritis or inflammatory joint disease. Popliteal fluid collection, as depicted by this in this picture. So this popliteal fluid collection in the gastrocnemius semi-membranous bursa between the two muscle tendons. So between the two muscle tendons of the gastrocnemius and semi-membranous. Gastrocnemius is the leg muscle, while semi-membranosus is a thigh muscle, the posterior thigh muscle, a hamstring muscle. So the bursa between them is commonly communicating with the synovial space, and the synovial fluid from the joint cavity can come inside it, and that is called as a Baker's cyst. And that happens in the patient who have osteoarthritis or inflammatory joint disease. Clinical picture: often asymptomatic, may cause posterior knee pain with a prolonged standing, symptoms swelling worse with activity, and rupture may cause acute pain that mimics the deep vein thrombosis. Okay, so these 2 points are very important. Like when the Baker's cyst gets damaged, the first point is when the Baker's cyst gets damaged or ruptured, there will be severe pain which will mimic the deep vein thrombosis, and secondly, it is commonly found in the osteoarthritis and inflammatory joint conditions. Then we have ankle sprains. So anterior talofibular ligament. The talofibular ligament is between the talus bone and the fibula bone on the lateral side. Okay, so anterior talofibular ligament. Most common ankle sprain overall always tear first, because this ligament is weaker in comparison to the medial ligament. So okay, due to the over inversion and supination of the foot, okay, present with the pain and ecchymosis at the anterolateral aspect of the ankle. Anterior inferior tibial ligament, most common high ankle sprain. Most common high ankle sprain is antero-inferior tibialofibular ligament. This one is antero-inferior tibialofibular ligament. Let me zoom it in. So anterior talofibular ligament, the anterior talofibular ligament. So this is anterior talofibular ligament. This one. So this anterior talofibular ligament is always going to tear first. Always tears first. Most common ankle sprain overall, classified as low ankle sprain pain. So if we have a low ankle sprain pain, we have some reference points by which we say them low or high. So if we have low ankle sprain pain, in that case it is the anterior talofibular ligament that has been damaged. And if we have high ankle sprain pain, so the anterior inferior tibialofibular ligament is damaged. The anterior inferior tibialofibular ligament is damaged if we have high pain. In low pain, this one ATL or anterior talofibular ligament. In high pain, AITL, that is anterior inferior talofibular ligament. Got it? Then moving to the next part, the femoral neck fracture. The femoral neck fracture is very common kind of fracture in elderly patients. So it is associated with the osteopenia and osteoporosis. It presents with severe hip and groin pain, which is worsened by movement and shortened externally rotated leg. These 2 points are very important, that whenever there is femoral neck fracture, there will be shortening of the leg with external rotation of the leg. Suppose there is fracture over here. So whenever there is fracture, this leg will move upwards, right? So when this leg move upward, the angle between becomes more perpendicular because of the fracture maybe over here. So that fracture will cause shortening of the leg. On top of that, there will be external rotation like this. The external rotation and shortening is associated with the femoral neck fractures. Treat surgically with anticoagulant DVT prophylaxis. So whenever we are going to do the surgery for this femoral neck fracture, we have to give the DVT prophylaxis, that is anticoagulant. Complications include risk of AVN, acute avascular necrosis of the femoral head to the medial circumflex artery due to the medial circumflex artery compromise. Medial circumflex artery, where is that? The medial okay, let me remove that, all of the things. The medial circumflex artery is over here. This is the medial circumflex artery and the lateral circumflex artery. So medial circumflex artery, if you can see over here, this is medial circumflex artery. This gives branches to the neck of the femur. Whenever there is damage to the neck, like suppose we are damaging it over here, so the branches coming from the medial femoral ligament, they can be compromised and there will be avascular necrosis of the neck in case there we have an acetabular branch of obturator artery which is moving through the ligament of the head of femur. So if this artery, the blood supply from the articular acetabular branch of the obturator artery is not enough to supply the neck, in that case we'll have avascular necrosis of the femoral head due to the medial circumflex artery compromise. Remember this thing, that head is being supplied by two arteries. That first one is medial circumflex femoral artery and second one is the acetabular branch of the obturator artery. If this artery cannot compensate for the loss of medial circumflex femoral artery blood supply, in that case we are expecting the avascular necrosis in the head of the femur due to the femoral neck fracture. Hip dislocation, it can either be posterior or anterior. So posterior, most common in 90% of the cases it is posterior. For example, whenever a person is having injury in the roadside accident and the knees hit the dashboard of the car, in that case there will be anteriorly, the dashboard will push the knees posteriorly and we'll have a posterior hip dislocation caused by posteriorly directed force on internally rotated, flexed and adducted hip. So suppose there is a person who is driving a car and is sitting like this, right? So there he or she is driving the car, steering wheel is over here. So whenever the dashboard hits the person like this, so in this position the knee joint is caused by posteriorly directed force on the internally rotated, the leg is internally rotated, flexed and adducted. So forget about the knee joint, we're talking about the hip joint. So the hip joint is flexed, adducted and internally rotated. In that case, whenever there will be a dashboard injury to this area, so there will be a posteriorly directed force exerted on this joint and the hip will be dislocated posteriorly. Limb is shortened, flexed and medially rotated. Remember that in the femoral neck fracture we were talking about externally rotated leg, and now in the hip dislocation we will find a medially rotated leg. Anterior hip dislocation occurs with the hip adduction. It occurs with the hip in abduction and external rotation. So it occurs with the hip in abduction and external rotation. So it occurs when the hip is abducted and externally rotated. Basically, posterior injury. Remember this picture. That just think about the internal rotation and flexion and adduction of the hip. And the opposite orientation will cause anterior dislocation when the forces are applied from posterior or something, when the hip is abducted and external rotation is there. Complications, whenever there is hip dislocation, so sciatic nerve that is passing in close relationship to the hip joint can be injured, so there will be sciatic nerve injury and avascular necrosis of the femoral head. Okay, so here you can see that whenever there is force directed in this direction, like the black arrow, so the hip will be dislocated posteriorly, and when the hip is dislocated posteriorly, so the limb is shortened, flexed and medially rotated. So there is medial rotation of the limb and the limb becomes shortened and flexed as well. What is patellar fracture? The cause of injury is direct impact to the anterior aspect of the knee. Excessive force transmitted through the quadriceps femoris tendon landing on the feet after falling from a height. So excessive force transmitted through the quadriceps tendon, for example, landing on the feet after falling from a height. So when a person lands on the feet after falling from the height, the quadriceps tendon will pull the muscle, the quadriceps femoris muscle will be contracted and the tendon will be pulling the muscle upwards, so that can cause a patellar fracture. Or maybe whenever there is direct impact, that can also damage the patella when the person is falling on the knee. Sometimes signs of patellar fracture: acutely swollen knee, focal patellar tenderness, inability to extend the knee against gravity, that is quadriceps insertion. So we cannot extend the knee, because whenever we are extending the knee, suppose we are trying to extend the knee, so the quadriceps femoris tendon will be contracted, so the force is directed in that direction whenever we are extending the knee. So this movement will be painful because the patella is also pushed upward. Now when the patella is cut in half, so this movement will be very, very painful. So that is why the person is unable to flex the knee, and the person will be unable to extend the knee joint, and the neck will be permanently flexed. Quadriceps insertion, palpable gap in the extensor mechanism. So in the extensor mechanism, you will be able to find a palpable gap, I guess over here, maybe lower extremity nerves. So now this is a kind of a nightmare, because the upper extremity nerves are coming from the brachial plexus, and brachial plexus is also simple in orientation, like the usual roots and trunks and uh, roots, trunks, cords, the yeah, stuff like that. Remember to bring roots, trunks, division, cords, and branches. So it was easier. But now when we deal with the lower extremity nerves, it is coming from the lumbosacral plexus. That is a very, very intricate structure. On top of that, the distribution is also kind of vague, so I find it very difficult. So I will try to simplify them as possible as I could, as much as possible, but to find some better videos for that as well. So let's come to the iliohypogastric nerve, the T12 to L1 innervation. The iliohypogastric nerve provides the innervation, sensory, suprapubic region, motor transverse abdominis, and internal oblique. So suprapubic region is being supplied by the iliohypogastric nerve, and the motor innervation is given to the transversus abdominis muscle and the internal oblique muscle. So these are both abdominal muscles. Cause of injury is abdominal surgery. Presentation: burning or tingling pain in the surgical incision site radiating to the inguinal and suprapubic region. This exact line is something that they give you in the step 1 question stem. So here is a good picture of iliohypogastric nerve, as it is originating from this region, from the spinal cord, the lumbar spinal cord, lumbar spinal cord, and from that it's going to start all the way into the anterior abdominal wall and the hypogastrium. So if we divide the, just give me a second. So if we divide the abdominal wall into quadrants like this, so we divide it into quadrants like that. 9 quadrants are being formed. So among these 9 quadrants, the lowermost or the central lowermost quadrant, this quadrant is called as the hypogastrium, right? So that is hypogastric region. So it is coming from this region all the way down. It's a pregnant woman, and the nerve was clear in this picture. That is why I'm symbolizing it over here. So here you can find the iliohypogastric nerve, and the ilioinguinal nerve is just below that. We'll talk about that as well. So this is iliohypogastric nerve coming to this region, and the ilioinguinal nerve is going to the inguinal region. So the hypogastrium, we have iliohypogastric. So the inguinal region, we have ilioinguinal nerve. So I guess this is a good picture. So here you can see the area of innervation of the iliohypogastric nerve. So this is the hypogastric quadrant of the stomach, this one, and on the lateral side this area is being supplied by the iliohypogastric nerve. Immediately below the iliohypogastric nerve on the inguinal ligament, across the inguinal ligament, you may say that that area is being supplied by the ilioinguinal nerve, and then we have genitofemoral nerve below that. And above the iliohypogastric nerve, we have area of innervation of the subcostal nerve. So just below the subcostal nerve is the area of innervation of the iliohypogastric nerve. I'm talking about the cutaneous innervation. And just below the iliohypogastric nerve, along the inguinal ligament, we have ilioinguinal cutaneous innervation. And just below that, we have genitofemoral nerve on the genitals, as well as on the just below the ilioinguinal nerve. So this is a bit confusing, and that is also very highly tested upon concept. So that is why I'm putting this much emphasis on this one. Ilioinguinal nerve and iliohypogastric nerve. So this is the ilioinguinal nerve, which is supplying the inguinal ligament, and the iliohypogastric nerve will be supplying this pretty much the same area, maybe area just above that. So coming back to our PDF, not this one, over here. So yeah, so the iliohypogastric nerve originating from the T12 to L1 vertebra, right? So it is providing the innervation to the suprapubic groin, and motor innervation to the transversus abdominis muscle and the internal oblique muscle. Presentation is burning and tingling pain in the surgical incision site radiating to the inguinal and suprapubic region, abdominal surgery. Okay. Then we have that is genitofemoral nerve. So genitofemoral nerve is coming from L1 to L2. Innervation is sensory scrotum, labia majora, medial thigh, and the motor innervation is to the cremasteric muscle. In the laparoscopic surgery, the genitofemoral nerve can be damaged. Presentation is decreased anterior thigh sensation beneath the inguinal ligament and absent cremasteric reflex. So cremasteric reflex will be gone because that is mediated by the genitofemoral nerve. Genito, as the name indicates, is that the cutaneous innervation is from the genital area, right, from the scrotum and the labia majora and the medial thigh, and the motor supply is by the cremasteric. The motor supply is cremaster muscle that causes the cremasteric reflex. That whenever we stroke the inguinal ligament or the medial aspect of the thigh, to be very specific, whenever we stroke the medial aspect of the thigh, the scrotum contracts. The scrotum is lined by the cremasteric muscle. So due to the contraction of cremasteric muscles, the testes inside the scrotum, they stand upwards. So that is the cremasteric reflex, and the cremasteric reflex will be absent in the case of damage to the genitofemoral nerve during a laparoscopic surgery. Lateral femoral cutaneous nerve. This is the lateral femoral cutaneous nerve over here. This one, the lateral femoral cutaneous nerve. So lateral femoral cutaneous nerve, it provides sensory innervation only to the anterior and lateral aspect of the thigh. The anterior and lateral aspect of the thigh is being supplied by the lateral femoral cutaneous nerve coming from L2 and L3, and the medial aspect of the thigh is being supplied by the genitofemoral nerve. Not complete medial aspect, but to some extent it is supplied by the genitofemoral nerve. So the sensory anterior and lateral thigh is being given the innervation, cutaneous innervation by the lateral femoral cutaneous nerve. Cause of injury: tight clothing, obesity, pregnancy, and pelvic procedures. And presentation is decreased thigh sensation, anterior and lateral. Anterior and lateral sensation of the thigh will be lost. So, revising it, the iliohypogastric nerve is damaged during the abdominal surgery, right? The genitofemoral nerve is injured during the laparoscopic surgery, and the lateral laparoscopic surgery. I guess that is one and the same thing, abdominal and laparoscopic. Okay, so the lateral femoral cutaneous nerve is damaged during the pelvic procedures and also with the tight clothing and obesity. What is myalgia parathetica? Pressure on the nerve close to the anterior superior iliac spine by protrusion of the abdomen in fat people may lead to the tingling sensation in the lateral side of the thigh. We are talking about the lateral femoral cutaneous nerve. So lateral cutaneous femoral nerve is over here, right? So in some fat people, if due to the body fat that is impinging on this nerve, pressure on the nerve close to the anterior superior iliac spine, like here the anterior superior iliac spine, if there is pressure on the nerve close to this one of the abdomen in fat people may lead to by protrusion of the abdomen in fat people may lead to the tingling sensation in the lateral side of the thigh. Moving forward to the obturator nerve. The obturator nerve, obturare, Latin means adducts. So motor to the thigh adductors. So obturator nerve is present over here, like this is the obturator nerve, and obturator nerve is a motor nerve mainly a motor nerve, but also supplies sensory innervation to the medial thigh. Remember that in the genital region, the medial thigh is being innervated cutaneously by the genitofemoral nerve, right? So suppose that this much area in the suppose this is the genital area, this aspect of the medial thigh is being supplied by the genitofemoral nerve. It is not even thigh. This aspect of the thigh is being supplied cutaneously by the genitofemoral nerve, and below that, the obturator nerve is supplying the medial aspect of the thigh. Secondly, the obturator nerve will adduct the thigh by sartorius muscle, I guess. So all the adductors are being supplied by the obturator nerve one way or the other. Motor to the obturator externus, adductor longus, adductor brevis, gracilis, pectineus, and adductor magnus. Okay, it is not supplying sartorius. So it is motor to obturator externus, adductor longus, adductor brevis, gracilis, and pectineus, and adductor magnus. The causes of injury is also pelvic surgery because it is because it is in close proximity to the pelvic region. Here is the obturator nerve, like this is the obturator nerve. So whenever we're doing the pelvic procedures, I guess C-section or something. I don't think that, because C-section is on the anterior wall that is coming from the posterior wall. So in the pelvic procedures, there is a chance of damaging the obturator nerve. Presentation: decreased thigh sensation, medial and adduction. So adduction will be weak. Along with that, the medial thigh sensation will be lost. Then we have femoral nerve. So femoral nerve is the area supply. The femoral nerve is over here. Obturator nerve. Just give me a second. I guess there's an atlas and there was some, cutaneous innovations and all that in the last pages. I guess obturator nerve was also given. Common fibular tibial sciatic. Yeah, here we have the obturator nerve. Obturator nerve is supplying this area, like over here. This area, the middle aspect of the thigh, is being supplied by the obturator nerve along with these muscles, which are this muscle is obturator externus muscle over here. Then we have adductor brevis muscle, then adductor longus muscle, which is cut, like the cut section of the adductor longus because it is passing below that. Then adductor magnus muscle, ischiocondylar or hamstring part supplied by the sciatic nerve. Okay, so adductor magnus muscle, but the ischiocondylar or the hamstring part is being supplied by the sciatic nerve, that is the tibial nerve. The tibial branch of the sciatic nerve, and then we have the gracilis muscle that is also being supplied by this one. So all the adductors, almost all the adductors, are being supplied by the obturator nerve, right? Then coming back to our PDF, now we have to talk about the femoral nerve. So femoral nerve, force of the femoral nerve, it descends through the fibers of psoas major muscle. Psoas major muscle, okay, emerges laterally between the psoas and iliacus muscle, and then run beneath the inguinal ligament into the thigh. So let's see this thing in the letter atlas. I guess there would be a picture of it. The femoral nerve. The femoral nerve. So femoral and the okay. So femoral nerve. This one is psoas. Where is psoas? Iliacus muscle over there. Psoas major. Okay. So this So we were talking about the cut section of the psoas muscle. So this is the psoas muscle, okay, and there's the iliacus muscle, and both of them together are called as iliopsoas muscle. And the femoral nerve, the nerve of our concern, is over here. So what were they saying? They said that it descends through the fiber of psoas major muscle, emerges laterally between the psoas and iliacus muscle, and then runs beneath the inguinal ligament into the thigh. So it is passing through the fibers of the psoas muscle and then laterally, so it is moving laterally, this is the lateral direction. So it runs laterally between the fibers of psoas and iliacus muscle, I guess, and then passing beneath the inguinal ligament into the leg, into the thigh. Okay. Emerges laterally between the psoas and iliacus muscle and then runs beneath the inguinal ligament into the thigh. Femoral nerve can be also injured by compression from the retroperitoneal hematoma anterior to the iliopsoas muscle. So here you can see that if there is retroperitoneal hematoma, because this is the abdominal confines, like this is the boundaries of the peritoneum and somewhere over here. So if there is retroperitoneal hematoma, maybe some damage to the abdominal aorta, right? Or maybe some damage to the renal arteries over there, some stuff like that. Whatever is there, that can result in retroperitoneal hematoma. That retroperitoneal hematoma can compress. If there is a hematoma developing over here, that retroperitoneal hematoma can compress and involve the femoral nerve as well. So remember this thing, because it is close, because it runs retroperitoneally and it is in close association with the iliopsoas muscle. So it can be damaged over there. Innervation. The sensory innervation is anterior cutaneous branch will supply the anterior thigh, as you can see over here. I will bring a clearer picture. And saphenous nerve will supply the medial thigh, medial leg. So anterior cutaneous branch is supplying the anterior aspect of thigh, and the saphenous branch is supplying the medial aspect of leg. So here is a better picture. This branch, that is anterior femoral cutaneous branches, these are supplying the anterior aspect of thigh, right? The lateral femoral cutaneous branch is supplying the lateral aspect of thigh. Then the infrapatellar branch of saphenous nerve is supplying the medial aspect of leg, and the medial crural branches of the saphenous nerve are supplying all the way to the medial branches, and the saphenous nerve is the longest cutaneous branch as well. So this nerve is supplying the medial aspect of the leg. So remember these cutaneous innervations. The anteromedial aspect of the thigh is being supplied by the anterior femoral branches. The lateral or anterolateral aspect of thigh is being supplied by the lateral femoral cutaneous branches, and the medial aspect of leg along with the medial aspect of foot, to this extent, that is being supplied by the saphenous nerve, and the infrapatellar branch of the saphenous nerve and the medial crural cutaneous branch is basically saphenous nerve, which is the branch of the femoral nerve. Okay, then moving forward, we have the motor nerve. So the motor nerve, the motor supplies to the hip flexors, which are iliacus, pectineus, and sartorius muscle, and the knee extensors, which are quadriceps. So this is the motor innervation, right? So the sensory innervation is to the anterior cutaneous branch will supply the anterior thigh, and saphenous nerve will supply the medial legs. To be simple, but we have also seen a detailed picture of that. And the motor supplies to the hip flexors, which are iliacus muscle, the pectineus muscle, and the sartorius muscle. Sartorius is a flexor, and sartorius is being supplied by the femoral nerve. Okay, the knee extensor, which are quadriceps. Got it. Then we have causes of knee injury. Causes of injury. The first one is pelvic fracture. Then compression by the retroperitoneal hematoma, as we discussed just now, anterior to the iliopsoas muscle, and saphenous vein stripping. Saphenous veins, what do they mean by that? Saphenous vein stripping. Saphenous vein stripping. Saphenous vein stripping means that okay, so whenever there is varicose vein, so we are stripping the saphenous vein, and in that we can damage the femoral nerve or maybe branches of that. Okay, so basically I guess it is the removal of the varicose veins, and that can damage the femoral nerve. Okay, so saphenous vein stripping can also lead to damage to the femoral nerve presentation. The presentation will be loss of the cutaneous and the motor supply. Definitely, motor loss will lead to decreased thigh flexion and leg extension, and difficulty with moving upstairs, because we need flexion of the hip joint to move upstairs. Also with coming downstairs, we need that. Sensory innervation, loss of sensation over the anterior and medial thigh and medial leg. Reflexes, there will be absence of the patellar reflex. Acute severe pain in the groin, lower abdomen, or back may also occur if the neuropathy is caused by the retroperitoneal hematoma. Acute severe pain in the groin, lower abdomen, and back may also occur if the neuropathy is caused by the retroperitoneal hematoma. Femoral neck block, femoral nerve block. Optimal site is inguinal crease and the lateral border of the femoral artery. So optimal site is For the femoral nerve block, optimal site is the inguinal crease at the lateral border of the femoral artery. So the inguinal crease, as you can see over here, that the femoral nerve is passing through the inguinal, below the inguinal ligament. So I guess over here maybe later to the, because moving later we have vein V, A, and then we have this nerve N. So inside under the inguinal ligament. So just later to the lateral border of the artery, we can give the femoral nerve block on the inguinal crease, right? Then we have here you can see this is femoral vein and artery and nerve moving laterally from medial to lateral. We get the vein. Anterior superior spine, lateral femoral cutaneous nerve is coming, but also even that lateral femoral cutaneous nerve is moving under the inguinal ligament. Nothing is moving over it. Femoral vein, femoral artery, then femoral nerve. Genital femoral nerve is over here. That is a different branch. We saw that, and that was supplying the medial aspect of the thigh above the obturator division or obturator nerve supply. Inguinal ligament, and then we have the pubic symphysis, liver, vena cava, aorta, kidney, psoas muscle. So there we have the psoas muscle, and retroperitoneal hematoma that is developing here. I guess this is a picture of the Uworld. So retroperitoneal hematoma that is developed over here can compress the femoral nerve, which would be passing somewhere over the iliacus muscle here. So it can be compressed or damaged by the retroperitoneal hematoma. The knee jerk reflex. So we'll okay. I guess we should do that. So the knee jerk reflex or the patellar reflex, tested by tapping the patellar ligament with a hammer to elicit the extension at the knee joint. Both afferent and efferent limb of the reflex are in femoral nerve. So L2 to L4. Femoral nerve is taking both afferent and efferent nerve supply of this one. This, the knee reflex. The knee jerk reflex tests the spinal nerve L2 to L4. Okay. So this is quadricep muscle over here and the hamstring muscle. Both of them are being supplied by the femoral nerve. The afferent limb is taken. So this is basically the basic physiology of any kind of any kind of tendon reflex, any kind of joint reflexes. So here you can see quadricep muscle. The cell body of the sensory neuron in the dorsal root ganglion will take the afferent signals to the gray matter, where there are interneurons connections, and then the alpha motor fibers will bring back the fibers and stuff like that. Then there's the hamstring muscle. So both the limbs, afferent and efferent, are being supplied by the femoral nerve, and the root value is L2 to L4. So we'll keep it till here, and the timer was a very bogus timer because I had to pause the video over and again because of the shifting process. So we are way above our 50-minute target. So we'll continue with this from the sciatic nerve in the next session. Until then, Allah Hafiz and Fi Amanillah. Take care.